Arthroscopic internal fixation for coracoid tip fractures. Here are our disclosures. To begin with this type of internal fixation, we first need to gain access to the coracoid. In this particular case, we clear out the rotator interval, and here you can see the biceps as well as the superior edge of the subscapularis, allowing us to see the coracoid. You can also see the motion in this coracoid because of the fracture. Some of the CA ligament will be removed here as to prevent it from holding back our reduction. Next, we will develop our D portal as seen in the cutout, and now we will clean out the tissue to the lateral aspect of the conjoint tendon. This is done with radiofrequency ablation. Once this is completed, we are then able to remove some of the tissue in the anterior portion of the conjoint tendon, which is subpectoralis tissue. At this point, we can establish our I portal, as this can be seen in the cutout to the top right. Once this is done, this is allowing us to get in line with the coracoid, and we can then develop a small rent in the anterior portion of the coracoid. This is where our guide pin and screw will later be. Next, we are able to develop our H portal, which comes in directly superior to the coracoid. Now we can remove some of the soft tissue, as our goal here is to develop and find our non-union site. Once this is found, we are able to take some of this fibrous tissue and soft tissue out of the non-union site. And then once this is complete, you can start seeing that we can move the tip of the coracoid. We'll have to clean up the edge of the bone here, and this will be done utilizing burrs and shavers. We obviously want to have a clean bone bed for good compression as well as good healing. Once we're able to almost completely remove the tip, we want to make sure that we'll be able to define it on all sides. And so we're coming around from the medial side and removing some of the pectoralis minor. We're leaving some of the soft tissue here to hinge it so that it does not become a completely loose piece of bone. Shortly, we will place a guide wire in it and we utilize this as a joystick, and therefore we will gain control of the tip of the coracoid so that we can fix it. Here the guide is positioned directly straight on, and this is coming through the I portal. We're going to place that guide pin through the central portion of that coracoid, and we have made that small rent in the conjoint tendon earlier. We'll stabilize it with either a probe or a switching stick, and here we can pass that guide wire through, and we're just trying to get to the end of the coracoid tip, which is the posterior aspect of this fracture. And then once we'll be able to do that, we can mobilize it and we can unhinge it from the medial side. Once it's unhinged, we can then direct it in the appropriate position as we're seeing here. Once the guide wire is positioned appropriately and we have control of the tip, we can position this on the native posterior aspect of the coracoid. This is again seen directly with the arthroscopy, and once this is in the appropriate position, we can place that guide wire through. Care must be taken to get to that second cortex and stop, as the suprascapular nerve and artery sit posterior to the coracoid in the suprascapular notch. Once we are happy with the position of our guide wire and the position of our coracoid, a cannulated drill is then used prior to placing our final implant. Here you can see that we have used the cannulated drill. Our guide wire stays in place, and then the final screw will come in, which is a cannulated 4.5 millimeter partially threaded screw, and this will allow for compression of this fracture. We made sure that our screw was all the way down to the tip of the coracoid, and we have to assess this through the conjoint tendon here, as there is some soft tissue in front of the bone, so therefore it does feel as though it is appropriately positioned but may look recessed through the soft tissue. We are utilizing our switching stick in order to make sure that we don't rotate, but we want to make sure that we're getting good compression at the fracture site. Final assessment is checked, and we're very happy with its position, and we are happy that it is a stable construct. We have taken down the non-union, and we are assessing this right here with the switching stick that we have good compression, and the final guide wire is removed. Here are final x-rays of the implant and the reduction of the coracoid. Thank you.